A very good morning, everybody. So today we're going to be covering on postnatal growth of maxilla. In the previous class, we had seen about the prenatal growth of the maxilla and how the maxillary bone ossifies. So in today's class, we'll be seeing about the postnatal growth. So just as the mandible remodels in a predominantly posterior manner, the postnatal growth of the maxilla occurs by displacing it in an opposite antero-inferior direction. The nasomaxillary complex also grows in a generally comparable way, which is there is bone deposition on the cranial base, which actually translates the maxilla downwards and forwards. So the postnatal growth of the maxilla, the nasomaxillary complex. So the maxilla actually should not be called as a separate bone. It should actually be called as a nasomaxillary complex because it also houses the nasal cavity. So this occurs by the following mechanism, which is the displacement, growth at the sutures, and the surface remodeling. So basically, as the name suggests, displacement is nothing but the movement of the bone as a whole because of deposition and resorption. Growth at the sutures is they consider the suture as the growth center where it causes increase in size of the maxilla. So let's cover the first topic, which is nothing but the growth at the sutures. So the maxilla is actually connected to the cranium or the cranial base by a number of sutures. The sutures are the frontonasal suture, the frontomaxillary suture, the frontozygomatic suture, the zygomatico-temporal suture, the zygomatico-maxillary suture, and the pterygopalatine suture. So these sutures are all oblique in direction, and they are more or less parallel to each other, which is why it allows the maxilla to grow downwards and forwards. Imagine all the sutures are actually erratically positioned in other directions. This will cause the maxilla to grow in all the dimensions. Okay. The next is surface remodeling. Remodeling occurs by deposition and resorption, as I mentioned before. So it causes increase in size, change in shape of the bone, and change in functional relationship. So the next is maxillary tuberosity and arch lengthening. So the remodeling at the maxillary tuberosity, which occurs at the posterior region, causes horizontal lengthening. It is a depository field and it causes lengthening and widening of the arch, which provides space for the eruption of the molars. So the clinical significance of this is that we can expand the arch by distalization of the molars into the area of bony deposition. The next is the alveolar ridge. The alveolar ridge actually is formed by bony deposition at alveolar margins. So there's bone deposition on all the margins. So this causes a vertical drift, which increases the maxillary height and the depth of the palate. So as there is resorption on the internal margin, the palate actually keeps deepening. Okay, this is how the depth of the palate increases. So similarly, as there's bony deposition, the height also increases. The next is palatal remodeling. So on the external labial side of the whole anterior part of the maxillary arch, there is resorption with bone being added onto the inside of the arch, and this causes increase in width and the palate becomes wider. So this follows the Enlow's V principle. Nasal cavity, the inner lining of the palate, which is actually the floor of the nasal cavity, there is resorption of bone, and on the aspect of the palate there is deposition. So this is also similar to the V principle. And this actually approximates the floor of the nasal chambers, which produces a lateral and anterior expansion of the nasal chambers. So similarly, the zygomatic region also undergoes remodeling. So the posterior surface of the malar protuberance is actually depository, as you see the plus symbol. And there is resorption on the anterior surface. And this is how the cheekbone relocates posteriorly. Okay, so can you see the arrow mark? This is the future position of the zygomatic bone. Similarly, on the inferior edge of the zygoma, there is deposition, and the anterior part hence becomes enlarged vertically as the face develops in depth. Then the maxillary sinus. The maxillary sinus has a lining cortical surface which are resorptive, and the mesial wall alone is depository, okay, as it remodels laterally to the to actually accommodate the nasal expansion. So the maxillary height, according to Bjork and Scilero, they confirm that the maxillary height increases because of sutural growth towards the frontal and the zygomatic bones, and an oppositional growth in the alveolar process. The maxillary width. So, as you all know, both the palatine shelves meet at the center by the median suture. So, growth in the median suture is more important for oppositional remodeling in the development of maxillary width. So, growth at the median suture actually mimics the general growth curve. You must have all read about Scammonn's growth curve, where there are 4 types of growth curves. So, the maxilla actually it follows the general growth curve for the body height and maximum pubertal growth in the median suture, which coincides with the time for maximum growth in facial sutures as seen in the radiograph. Then comes the maxillary length. So the maxilla actually changes in height, width and length. Okay, so the length increases in the maxilla after about the 2nd year, which occurs by apposition on the maxillary tuberosity, the posterior part. So this causes lengthening of the maxilla. Okay. So there are few basic theories which actually help in explaining how the maxilla grows. So the first one is remodeling theory by Brash, which was given in 1930. This is the first general theory of craniofacial growth. He postulated that all the growth occurs mainly by bony remodeling, and the sutures and cartilages have little or no role in growth of the craniofacial skeleton. So the growth of the jaw is characterized by either deposition of bone at the posterior surface of maxilla and mandible and some amount of resorption. Okay. Next is the sutural dominance theory by Wieman and Seischer, which was given in 1940s. And this theory says that the nasomaxillary complex is actually attached to the cranial base by a number of sutures which push the nasomaxillary complex downwards and forwards. So the third theory is the nasal septal theory or the cartilaginous theory by Scott, which is given in 1950. He considered that the nasal septum is actually the active and important part of the craniofacial skeleton, which causes growth. Okay, so during which time the inferior growth of the nasal septal cartilage is buttressed against the cranial base posteriorly, and it drives the midface downwards and forwards. He also found out that when the nasal septum was surgically removed, the midface actually showed deficiency. There was midface hypoplasia. Okay, but according to today's consensus, this theory does not hold good. They say that the nasal septum is actually not responsible for the growth of the maxilla. So the next theory is the functional matrix theory by Moss, which was given in 1962. And he says that the original form and position and growth of the skeletal tissues is always secondary and compensatory and mechanically obligatory, necessary response to chronologically and morphologically prior events or processes that occur in specifically related non-skeletal tissues, organs, or functioning spaces. So what he generally says is that the growth of the maxilla and the mandible is the enlargement of the nasal and the oral cavity, which grows in response to functional needs such as breathing and mastication. So the more the patient breathes, develops his breathing skills and mastication, the related structures grow. Okay. So now we move on to the Enlow's V principle, which I mentioned before. There are many facial and cranial bones in the head and neck region, which have a V-shaped configuration. So it's an inverted V, where on the outer aspect there is resorption, okay, and on the inner aspect there is bony deposition. So this causes widening of the V. That is how the mandible develops. That's how the maxilla also develops, which is mainly the palate. Okay. Then there's Enlow gave another principle called the counterpart principle, where growth in any one region of the skull influences growth in another region, so that functional equilibrium is maintained. If, for example, if you take the maxilla and the mandible, based on the growth of the maxilla, the mandible also grows. Okay. Based on the growth of the cranial base, the maxilla grows. So this is the counterpart principle. Okay. So now we move on to the anomalies and clinical implications. Like what happens if the growth is affected prenatally and postnatally? So the first and the foremost defect is cleft lip and palate. So cleft lip and palate is one of the most common congenital defects these days, which occurs due to failure of fusion of various facial processes, like the median and the lateral nasal process and the maxillary process, which causes cleft lip. So failure of fusion of the palatal shelves causes cleft palate. Okay, so these are the pictures of cleft lip and cleft palate. Then there's microstomia and macrostomia, which is nothing but smaller mouth and a larger mouth, larger opening. Okay, so merging of the maxillary and the mandibular prominences beyond or short of the site for normal mouth size results in a mouth that is either too small or too large. Okay, so this child has a smaller opening, whereas if you see this child, it has a larger stomatodium, larger mouth. Okay, and then there's this oblique facial cleft, which is the persistence of the groove between the maxillary prominences and the lateral nasal prominences running from the medial canthus of the eye to the ala of the nose. Okay. Then the final topic is clinical significance. So the maxilla is actually developed from the first branchial arch, which is the mandibular arch, and the ectomesenchymal cells. So if there's any etiological factor that affects or interferes with the function of this structure, it may give rise to an underdeveloped maxilla. Okay. Maxilla also forms the middle 1/3 of the face. So any underdevelopment may be caused if there's any trauma to the face, to the mid face region. Okay. And the mid-palatine suture actually closes around 15 to 18 years of age. So the transverse growth occurs until then. So we have to utilize this period to cause expansion of the arch, like for example, RME, which is rapid maxillary expansion, or slow maxillary expansion. Then the maxilla is surrounded by an envelope of facial muscles, which is restricted, which causes restricted growth if there's any defect to the muscles, and this will in turn cause the growth of the maxilla to be deficient. Then there's vertical lengthening of the maxilla, which is equal in both the anterior and the posterior regions, and in discrepancies it can cause open bite or deep bite. Okay. Then the development of dentition is directly related to development of alveolar bone, which in turn is related to vertical height. Then the maxilla to the relationship of the maxilla to the cranial base. So if you see, 82 plus or minus 2 is the normal value according to Steiner's analysis. If there is if the value is less than 80 degrees, there is retrognathic maxilla, and if the value is greater than 84 degrees, it causes prognathic maxilla. So as you all know, I've already mentioned before, the body of the maxilla follows general growth curve, but in general it follows more of the neural growth curve. Okay, so we have to utilize this growth spurt to induce growth in the maxilla. For example, giving them a headgear or a face mask. Okay, and finally, orthognathic surgery has to be done only after active growth of the maxilla is complete. Okay, so thank you.